This is Dr. Kathryn Dao reporting for Room Now. I'm at ACR 2021 Convergence, and I am so excited to introduce to you a new field in rheumatology, geriatric rheumatology. It's an area of high need, but very limited attention. And I have my friend and colleague, Dr. Makris, as well as a lot of her buddies who have been so instrumental in getting this field to move forward. I'll have each of you introduce yourselves, your area of interest in particular, and what you're doing so far. Una, would you like to lead?
Sure. My name is Una Makris. I'm an associate professor at UT Southwestern Medical Center and the Dallas VA. I am so thrilled to be here. Thank you, Kathryn. And thank you to my colleagues for being here and making such an exciting ACR 2021, where aging has featured so prominently. I have been passionate about the intersection of rheumatology and geriatrics for my career, and I focus on musculoskeletal pain and comorbid depression in older adults, and we've developed a novel behavioral intervention to improve outcomes that matter most for older adults.
Great. What about you, Kathryn?
Hi, I'm Katherine Wysham. I'm at the VA Puget Sound, and I'm junior faculty at the University of Washington. I'm interested in osteoporosis, which tends to be a disease of older people. And in diving deeper into osteoporosis, I became very interested in the concept of frailty. And with some collaborations and discussions with Una and Devyani and Sebastian, I've really become more and more interested in aging as a general concept. It's very applicable to my patient population at the VA. So starting to become more of a passion in this group is very wonderful. So with this, maybe I can hand it off to Sebastian.
Hi, so I'm Sebastian Sattui. I'm an assistant professor at the University of Pittsburgh, and I direct the vasculitis center here. So this is kind of my, I guess, how I joined this group, because my particular focus is in kind of treatment and outcomes of patients with vasculitis and PMR. And I got constantly reminded of kind of the age group that I deal with in clinic every day, that needs for this for our patients that go way past and beyond what we conceive as typical outcomes of our diseases. So that's how I became particularly interested in frailty and other age-related outcomes as well, such as cognition. And I found a home in this group. So this is kind of a little bit of the work that we're doing and pushing forward.
Devyani, go for it.
Hi, I'm Devyani Misra. I am an assistant professor at the Harvard Medical School. I'm a geriatrician and a rheumatologist, so I'm double-boarded, and it is very natural for me to marry the two divisions, the two fields of geriatrics and rheumatology in what I practice, as well as what I research. So my particular interest is in geriatric outcomes of functional limitation and frailty in patients with osteoarthritis.
So could you all tell our viewers why it's important for rheumatologists to learn about aging? And I'm just going to throw this out to everybody.
I think it's important to just recognize in our clinical practice, we're seeing more and more older adults. And my question always is, are we prepared as the rheumatology workforce to adequately and appropriately take care of our aging patients? And that's where I've learned so much from our geriatrics colleagues and experts. What can we adapt and take from the geriatrics field, apply it in rheumatology in order to improve outcomes for this rapidly rising population?
You're absolutely right. I mean, not only are we, our patients getting older, we are too. And some of the things that you are going to be mentioning today probably is something that we can take with us, as well as for the other population groups as well. So how can we improve care for the older rheumatology patient?
I think that's through creating awareness how the needs of geriatric patients are different from the young adult patients we take care of. The unique challenges a provider faces when taking care of an older adult, and how do we tailor treatment according to the comorbidities that come with aging. And also, more importantly, sometimes I think we will briefly be touching on it, the ageism part, where we just assume that older patients do not want treatment, but actually we should be asking them what their goals are, what matters the most to them, and tailor the treatment according to what matters most to them.
Can you go more into the 5 M's?
Absolutely. We've emphasized that quite a bit during ACR now. And let me just recap what the 5 M's are. An age-friendly healthcare system often adopts the 5 M's. The 5 M's of aging include multi-complexity. It includes what matters most to patients, because really our values and priorities change as we get older. It includes mobility, where we talk about ambulation and we talk about fall risk. It includes medications and polypharmacy, potentially deprescribing. And it includes mentation. Mentation encompasses comorbid depressive symptoms and anxiety, as well as delirium and dementia and the whole spectrum of cognitive impairment, which has been highlighted in several abstract and plenary sessions during this ACR 2021.
Kathryn, I get the 5 M's, but I want your perspective. Like, how are we as clinicians able to incorporate all that when we have such a limited time with our patient? I mean, we have to go through, their medicines, and then we have to check their labs and make sure they're vaccinated, talk to them about COVID. Give me some hints here.
Yeah, I find that it weaves its way into practice. You get to know your patient, you get them stable with your primary goal, which is their disease. But as you're working with them, you're talking about what are their preferences, why are we treating them, what do they want to do after they're feeling much better. And that breeds more and more kind of conversations about how can I get you as functional as possible? How do I, with COVID, I talk to my patients about social isolation. How do we navigate social isolation for my patients? How do we find safe spaces for them to interact and to get back into their communities? So I find that these things happen naturally. You have to just kind of pick up on it, spend a little time on it, compare and address your pressing needs, the patient needs, and then I always add one kind of healthcare maintenance tool into each visit as we get through the initial treatment of disease activity. So I think it's something, if we had more time, if we had this wonderful multifaceted geriatrics clinic, we could probably be more effective. But I think it's something that naturally we can chip away at over time.
And I think it's important because we all know we have the opportunity that we end up seeing our patients way more frequently than a lot of other providers. So when they are at the beginning of the disease, where they're having a flare, we keep such a close communication, and I think we can really kind of take that opportunity. And the same way as when I see a GCA patient and I know which symptoms I go through medications, and we have all the scripts that we have. It's just inserting these other factors that have been so successfully implemented in geriatric care that we can just bring it into our practice. And I think, like Kathryn said, it just becomes something very natural. As for me, just like asking for job location, PMR symptoms, and headaches and stuff like that, it's just something else to add on, which challenging, but I think naturally it can become, and it's such important for our patients as well.
Sebastian, I just want to piggyback on that. I actually think we often ask all of the 5 M's. It's integrated in what we do, but it's a reframing of this in the context of almost like a checklist for aging. Maybe we don't ask often enough what matters most to you, but in the social history or in the HPI, I think it naturally comes in. What are the things you enjoy doing? And in my mind, I'm already trying to frame the management plan around that. So in that way, it motivates the patient to engage and do what we want them to do. It improves their outcomes, most importantly, to engage in these conversations.
Yeah, and we need buy-in too. We need buy-in from everybody, because I've sent a patient to physical therapy, but then the therapist is like, sorry, we can't help them. They don't see any room for improvement. I mean, how are you going to address that if not everybody's on board?
I think that goes in both directions. Who is your physical therapist? Number one, we talk a lot about developing interdisciplinary teams and finding the right team members who are comfortable with musculoskeletal pain, inflammatory arthritis, and aging. And then also just referring a patient somewhere when they're not ready to go, or they may not perceive that this is an issue, we're often not effective. So gauging buy-in, as you said, Kathryn, and motivating our patient to get there makes a big difference.
Devyani, do you have anything to add to that? I mean, you had mentioned ageism before. Could you tell us a little bit about that? I know it's kind of discriminatory when you use that word, but give us an idea of what you're talking about.
I think we had a discussion at the Aging Hub yesterday. Like any other ism, ageism is a problem, and it's highlighted by the WHO now because it is a growing problem, and it's across all continents, all countries. And what it is basically by definition is a stereotype or a prejudice or discrimination based on age. And it doesn't always mean too old. It also refers to too young. But our older adults bear a brunt because of the how deep it percolates both in individual level, at societal level, and everyday life and healthcare. So that's what I was alluding to when I said the ageism in medicine, like we never ask our patients how aggressive you want us to be in terms of treating them. Perhaps I gave an example yesterday, how a 94-year-old woman, and my colleague asked, how do I treat her? And my response was, how would you treat a 54-year-old with gout? So same with them, and how the patient has done great on steroid taper for acute gout and allopurinol for tophaceous gout. So it's that stereotype I'm talking about, not just in the society, but in the medical field.
And
I'd love to.
Sorry, Katie, go ahead.
I was a quick add-on from a data standpoint, as we're looking at frailty in different data sets, and you see, even though in the frail group that they may not be, glucocorticoids may be more harmful in these folks, you see a higher use of glucocorticoids and a lower use of DMARDs and biologics. And I think we all have had that patient interaction where we're afraid of the known outcome of infection. And for some reason, there's this inherent comfort with glucocorticoids. And so we may not be treating our older patients in the safest way. So really kind of stepping back and really thinking about, is this patient someone who can tolerate a biologic for some of our hard stop, reasons why not to use it, and treating them similarly to a younger patient. And many of our older patients have, decades left to live. So anyway, sorry, Una.
It's important for us as healthcare, the healthcare team or physicians to change and work on changing this concept, because they're also very inherent to patients, and patients have the same concerns of like, no, that's up, now that we're talking like, again, GCA I use as an example, but tocilizumab and injectable medication, and people get super concerned about it, but we know now the benefits and how the steroid sparing effects, and that conception of like, oh, I'm maybe too old for this medication because injectable, it's going to be too hard. That is something that we have the data, so we need to kind of clear some concepts, rely on the data, educate ourselves, but educate our patients as well.
So in the last couple of minutes that I have, I'm just going to go around to everybody. If you can tell me what's the most important thing our viewers need to know, what kind of initiatives you're having. I think that, this will highlight this topic and just really allow us to learn more. So Una, you want to start?
Sure. I'd like to make 2 points, and that is, to really get to know your patient as they are growing older and recognize some of the unique aspects of aging through the 5 M's. And I think that the 5 M's it's really a brilliant, streamlined approach that you can integrate into a busy practice. And then secondly, please do come to some of our ACR Aging Community Hub activities. They are all audio recorded, and we've had wonderful discussions about ageism and identifying our own biases as we take care of aging patients. We also have symposia focused on multi-complexity. Tomorrow we have a symposium on frailty. All of these are really designed in an effort to educate our rheumatology colleagues on these important concepts.
Kathryn, you want to go next?
Sure. First, I'd say for our colleagues to, I think we treat diseases really well. We're taught to do that. We know our medications, but just to add one new tool to your toolkit, as you can, as you have the space, really focusing. I find that I have themes as I go through my clinics. This is the theme of the next 6 months, is I'm getting everyone's bone health up to snuff as I see them. Really just trying to push yourself as a provider. And from a patient standpoint, continue to advocate for the things, making sure that you're heard, I guess, making sure that your hopes, dreams, desires, and your plan is heard by your provider. Sometimes we get a little bit, hyper-focused because we're rheumatologists and we're really concerned about your primary disease. But, if your medications are making you not functional, or if something else is coming up, just making sure that you're heard, because I know all of us rheumatologists, we care about our patients deeply. Sometimes we just have our blinders on.
Sebastian.
I think we know who our patients are, and this is something that goes way beyond and covers all the different specific disease silos of rheumatology and how we behave. And we have, fortunately, in our group people that are in DRA and kind of lupus and vasculitis. So I guess Jerry Rheum is here to stay, and we look forward to growth in the community as well. And for anyone interested, I'm going to make the pitch that we have a joint email for our group. It's jerryroom@gmail.com.
Fabulous. Devyani, I'm going to let you close this out.
All right. So remember, elderhood is the third phase of life. It may be different, no less, no more. And aging is physiologic. So at the stage of elderhood, you may have graying of hair and wrinkling of skin, but treat your patient, not just your disease.
Beautifully stated. So this is Dr. Kathryn Dao. I want to thank my panel here for sharing with us information about how to take care of the older rheumatic disease patient. Continue to follow us on Twitter, read our blogs on rheumnow.com.